Good morning, Samantha. Thank you. It's so great to be here with all of you.
Yeah, good morning, everyone. I think I need to shut down the other session because I can hear something. So let me see if I can.
As we have folks joining, please go ahead and use the chat to let us know who you are, what organization you're with, maybe what region of the state you're from or another state. If you have pronouns of choice, let's go ahead and use the chat to kind of let everybody know who we are and who's here, because we definitely won't be doing a round of introductions. I'm still admitting folks. Donna's introduced herself. Thanks, Donna. Everybody else, go ahead and take a second to throw your name and who you're with in the chat so we have a good idea of who's with us today. Awesome. Yakima Valley Farm Workers, Pacific Source Alliance for Kids. Hi, Doug. Unite Us. Hi, Manu with Capital Dental. Awesome. It's a party. Great. I'm Samantha Shepard with CCO Oregon. Thanks for all coming to the first breakout session ever virtually hosted by CCO Oregon. We're in a whole new world. You didn't even have to wear pants to come today, so I hope you've been enjoying the conference. For everyone's notice, this session will be recorded. So please, as always, whether or not it's being recorded, please be patient, be respectful, understand we're coming from various avenues and different perspectives from across the state. We don't have captioning or American Sign Language during the breakouts, unfortunately. So please make sure we're avoiding acronyms and speaking slowly. I probably need to be told the most of that. And speaking clearly as we move through today. So we're going to be talking about sustained community investments, and we heard from Pat Allen this morning about where the 1115 waiver is at in the process. But I think most of the folks that are probably attending the CCO Oregon conference heard about the health equity zones back in the day and know that we have House Bill 3353, which allocates some dollars, some percentage to social determinants of health from the CCO revenue. And of course, just overall, we're all focused on health equity and social determinants and that investment. So let me go over a couple of rules of the road. So I've already mentioned that we're being recorded and we need to speak slowly and make sure we're avoiding acronyms at all costs. For folks that might not use Zoom all the time, if you move your cursor down to the bottom of the Zoom screen, a control bar will appear. And on the left-hand side, you can click on the mute button to turn your microphone off or on. Please leave it off until you're asked or requested to speak. You can turn your video on or off, but please leave it on because you're lovely and it's nice to see faces. You can then click on participants and see who is here with you. If you right-click your name in the participant list or on your screen where you see your face, you can change your name, your pronouns, your organization, anything else you like. If you need to open the chat, you do that by hitting the chat box. And we do have the ability to have folks share their screen as we're all sharing, as we're all talking today. And if you want to react to something, if you want to say, yeah, I agree with that by clapping or giving a thumbs up, or you want to celebrate something, you can use the reactions button to bring up a bunch of different options. And if you're looking at the control bar and some of those features aren't showing, then use the little 3 dots at the end above the word more, and a drop-down menu will appear with other controls for you to be able to engage in the conversation. Okay. We are going to ask people to raise their hands because there's a lot of us and we all have important things to say. And just a little bit of framing here. So as we heard, the Oregon Health Authority is currently drafting the next 1115 Medicaid demonstration waiver. And the 1115 waiver is a negotiation essentially with the Center for Medicaid and Medicare Services, or CMS, that will guide development and innovation of the Oregon Health Plan for the next 5 years, beginning in January of 2023. You can learn more about OHA's work on the 1115 waiver renewal and how to provide public comment at a link that I'll throw in the chat in just a couple of minutes. So you can go to their webpage and learn more. And today we're talking about sustained community investments that are locally led and accountable, and they need to be maximized as our communities experience greater challenges with health inequities, houselessness, lack of transportation and broadband, particularly in frontier areas and communities, and harsher and more frequent climate crises. The coordinated care model positions CCOs as hubs that convene and connects folks across our communities to deliver services and connect providers. And there's recent legislation, CCO contracts and conversations of behavioral health all across the board that are focused on increasing community-led decision-making and investments. So the next waiver is really going to further this work. So we're going to begin with a couple of perspectives and just to kind of frame the conversation, and then we'll open it up to any experiences you want to share or questions for anyone on the call. So Michelle, let's begin with you, and you can also introduce your colleague Annie that I believe has joined you today.
Good morning. Thanks so much, Samantha, and good to see you all. My name is Michelle.
I can't hear you, Michelle, but I can see that you unmuted.
Oh,
you can hear her, Donna? Okay, then it was just me. Go ahead, Michelle. It's just me.
Oh,
I'm so
no.
sad. I will figure out my problem. You go ahead, please.
Okay, wonderful. Thanks, everyone. It's good to see you all. My name is Michelle Glass. I use she and her pronouns, and I am the Policy and Advocacy Coordinator for So Healthy, which is the Regional Health Equity Coalition of Southern Oregon, serving Jackson County and Josephine County. And my colleague and our director, Annie Valtierra Sanchez, is here with me today as well. And a quick, there she is waving, a quick physical description of me. I am a white woman with shoulder length blonde hair. I'm wearing a black jacket and my Zoom background is blurred out because I'm still coming to you from my living room. And I'm really excited to get to be with you all today. I'll let Annie introduce herself.
Morning, everyone. Thanks for the invitation. This is like a first and really sudden, so I'm glad to see so many people on board. My name is Annie Valtierra Sanchez, as Michelle introduced me, Director for the Southern Oregon Health Equity Coalition, and glad to be here. Pronouns she and hers.
And then Samantha, do you want us to just go into the, okay, wonderful. So we are really excited to be here today to share a little bit about why we were so involved in championing, along with many partners across the state, House Bill 3353. And this bill, this important bill, historic bill, we really see as an opportunity to build the sustainable infrastructure that we need and that our community has been asking for years. That works to develop and maintain new systems of health, new programs and investments, most importantly, aligning investments that allow us to achieve what the state and Regional Health Equity Coalition partners and many of you have been working towards, which is recognizing, reconciling, and rectifying historical and contemporary injustices that impact all of our health. So this important bill does a couple of things. It requires the Oregon Health Authority to seek approval from the Federal Centers of Medicaid and Medicare Services to spend 3% of the global CCO budgets to improve health equity in a really targeted way. Of that 3%, 30% would be to reinvest in community-led efforts to achieve health equity with a real emphasis on racial and ethnic disparities in healthcare. 20% of that 3% would be for behavioral health and crisis services, something we've all been thinking and hearing a lot about in the last couple of years. And 50% of that 3%, finally, the last 50% would just be for more general social determinants of health initiatives. And one of the things we're really excited about is that across these areas of investment, there is a real focus on the deep racial and ethnic disparities, as well as all of the other important intersecting ways that people's identities and our systems and structures impact health. So it's really key for the health equity coalitions and for So Healthy especially. And also there's a big focus on, because of that, cultural and linguistically appropriate care, something that, again, our community is really asking for. And we're excited to see that focus. And then finally, community voice and leadership. So I think this, because of these components, this bill really could be a game changer in terms of finally moving the needle on some of these longstanding inequities in health and in wellness for individuals, families, and communities across Oregon. And then finally, the one other thing I wanted to mention is that the bill calls for the Oregon Health Authority to set up an oversight committee that includes representation from the regional and demographic diversity of our state, and that really centers community and consumer voices to play an active and intentional role in guiding these new investments and in evaluating their effectiveness. So I think that component gives us a lot of confidence that we can. This is something really new, and that we can continue to stay accountable to the communities who are most impacted, and make this the most powerful and transformational opportunity that we all want it to be for health for our communities. This bill was passed with bipartisan support, which was wonderful to see in the House and the Senate on June 17th, and it took effect on September 25th. So Annie, I don't know if there's anything you'd like to add.
I think you did a great job in summarizing. There's so much to it, and I'm hoping that everyone here gets a little more involved in the process. I know I can add that our regional health equity coalitions, existing coalitions, work really hard to get this as a bill from a legislative concept to a bill to passing it. And now we're really looking to implementation. So the other thing I can add is that being, especially in this platform, we are very conscious about, or very aware, and want you all to be aware of the parity that we hope to see across CCOs and implementation. We know that this is the process right now in getting it to CMS, but I feel like we have made a commitment to see it through because our communities really need this change. Seeing this bill as a long-term investment of 5 years, we don't want to come back 5 years later and be thinking, did it work? Did somebody do something? Who dropped the ball? We really want this to be something very thoughtful from the beginning, and especially in the implementation and oversight. Thank you.
Thank you, Annie. Thank you, Michelle. And Donna, we've asked you to also share some thoughts on your perspective based on your work with the Central Oregon Health Council. Would you like to share?
Yep. Good morning, everybody. And thank you, Sam, for having me. And I am privileged to present alongside Michelle and Annie. And anybody that knows me knows that I am not short-winded. So I tried to be as concise as I could to lead out today. So here we go. So I am Donna Mills, and I serve as the Executive Director of the Central Oregon Health Council. The Health Council has been executing our most current regional health improvement plan for the last 18 months, and this plan is the 2020 to 2024 plan. Our model is unique in the respects that the Coordinated Care Organization, or CCO, has created a relationship with the Health Council, not unlike a community arm of the payer. We're able to partner with our communities to guide and align vision, strategy, and activities across industries for a healthier Central Oregon. We provide the data through the Regional Health Assessment, and that is the foundation for the Regional Health Improvement Plan. By the way, the Health Council is an autonomous 501c3 and is also supported operationally by our CCO, who is Pacific Source. I want to highlight this morning how the community makes decisions about where and what to invest in the community. As mentioned, the Health Council has responsibility for activating the Regional Health Improvement Plan. And the pillars of that plan are decided by our Board of Directors and our Community Advisory Council, mostly known as CACs, around the state. But prior to those final decisions, the community comes together and uses the data from the Regional Health Assessment to determine where they can be the most impactful. They then relay the information to the Board of Directors and Community Advisory Council. And once those decisions are made, the pillars are chosen. The community then reconvenes to determine which of those current state data points found in the Regional Health Assessment have risen to the top, so that they'll be able to actually affect on things that can actually be affected, and to what degree they can be affected throughout the community. So it might be by a percentage or a number of touches of folks in the community. The Health Council has a staff of 6, including me. We run really lean, And we have 3 highly trained project managers that shepherd 6 work groups, a grants and metrics manager, and admin support. The work groups meet monthly and consist of healthcare providers in the traditional sense, which are thermometer and stethoscope in my world, non-traditional healthcare providers, which might be social services or community-based organizations, public health representatives, and community members. Those folks go through a rigorous root cause analysis process to determine where entry points exist to affect the current state data points. And the Health Council, we just act as facilitators for the work, and we do not make the decisions for the community. Each work group has $2 million to invest over the course of the Regional Health Improvement Plan, which is 5 years for a total of $12 million. And some of the investments that have been made to date, and there are lots of them, are our prenatal care continuum, where public health has partnered with OBGYNs in the community to elevate high-risk pregnancies, partnering folks with substance use disorder with a peer mentor to reduce emergency room visits and encourage recovery, supporting diabetes prevention programs, which are still not a covered benefit. Juntos Aprendemos, which is promoting children's social and emotional well-being by bringing pre-kindergarten kiddos into the classroom with their parents prior to school beginning to familiarize the parent and child to the classroom environment. And most of these parents do not speak English. Culture of care, which is intended to improve graduation rates by placing 3 trauma-informed professionals in the school system to train all folks that interact with our students, and that means cafeteria attendants and teachers and janitors, to recognize trauma-induced behaviors and refer these kiddos to the appropriate help they need. We're also supporting restorative justice and equity that provides for practices to raise student retention and graduation rates. And one that most likely will sound familiar to most of you is Connect Oregon or Unite Us, which we served as the pilot to bring better communication between social services, traditional healthcare, patients, and community with a community information exchange. Those are just a few of the many investments our work groups are participating in. And I would be remiss if I didn't mention the close to $500,000 of investments that were made during the 12 months of the first 12 months of the pandemic. And these were all not to exceed $5,000 investments and ranged from food to personal protective equipment. And the work groups actually chose to use some of their investments funds to create these pools. While we strive to meet the needs of our entire region, Crook, Jefferson, Deschutes counties, Confederated Tribes of Warm Springs, and Northern Klamath County, we're only as impactful as those that we're able to bring to the table. If you're interested in learning more of how or what we do in our region, we would be happy to hear from you. Thanks so much.
Thank you, Donna, Annie, and Michelle, for all sharing your experience and kind of where you're at on some of the work that we're already doing in our communities, but will be furthered by the 1115 waiver renewal. There's a lot kind of, I think, on the line for what we all hope can be with a true global budget and meaningful sustained investment. When I think for me, for CCO Oregon, and just for myself, when we think about community investments, moving towards a true global budget, talking about a cost growth benchmark, all those things, is also about moving from like a grant-based structure to a sustained community investment where, you know, year after year, we can really plan for what workforce is available for these programs, and there's not a funding cliff, and we're quite frankly not wasting time with administrative hurdles of just refunding the grant year after year after year, and really also thinking about from a healthcare perspective how the costs in these investments get counted as medical cost and medical spend, so that they then our rates and our healthcare system is better reflecting that whole person care that we're all really moving towards, and not medical over here and social determinants over here, but really whole person financing for whole person care, if you will. But let's open it up. We've heard from a couple of folks now, just to kind of frame the conversation. Who would like to raise their hand and share what's happening in your community, or have any questions for the folks you've heard from so far, or just kind of an en masse question for the group? Does anyone want to get the conversation started? See no hands up yet. Does anyone want to? Oh, Maggie, go ahead.
Hi, good morning. Thanks so much for the presentation so far. Michelle, I was wondering, could you talk any more about the behavioral health and crisis investments that are going to be made and what that's going to look like as the investments go forward?
Thanks, Maggie. I know that this is something that, you know, is really important and getting a lot of discussion across the state right now. You know, I think the bill itself, I'm not as involved in the implementation. That's the work Annie is doing. But the bill itself really clearly protects that 20% of the 3% of the global budget for behavioral health and crisis services. And then within that talks about things like, you know, linguistically and culturally appropriate care, and is really designed to align the resources that communities across the state need to provide the interventions for behavioral health and crisis intervention that we have been hearing, I think, from every region is needed. And so I think with the local oversight committee, the intent is that it will be very, the resources will be there, and then it will be determined by the community what that looks like in each community based on the needs of the community and the disparities. And so that's kind of the initial, and I'll drop the link to the full text of the bill here for folks who are interested in looking at, you know, what the bill itself calls for. But I think, you know, as Samantha shared, the next step is getting the negotiation that this flexibility from the federal government, getting them to agree to that, and then putting that oversight committee in place so that we can customize those investments for each community's needs.
Thanks, Michelle. I also put a link in the chat to the waiver page that the OHA has. They are expecting to release updated concept papers at the beginning of November, and then there'll be a formal public comment period in December. So there's information on that page. You can also sign up for text and email alerts and reminders, so you can never miss a nugget of information being shared about the 1115 waiver. So Michelle was just kind of talking about the implementation and how there's still a lot of steps ahead. You know, for any good law, it doesn't just pass and then magically happen. There's a lot of work, right? So here's a question for the group. What sort of community-based organization supports do we need to help them to change their inner workings to be able to move away from grant-based structures and really, you know, work in this different world? I mean, it is going to change contract relationships and just how we think about our partners at the table. Does anyone have thoughts on what supports community-based organizations might need, either from CCOs, RHECs, or the state agency? Any CBOs out there? Oh, go ahead, Annie, please.
I can jump in. I definitely, that's part of the model. So we have worked with a team from OHA, the Regional Health Equity Coalitions have worked with a team from OHA in looking at a model, right? What would it look like? And especially in creating a sustainable infrastructure for CBOs, community-based organizations, that will be not just, we keep seeing or have seen through the pandemic, you know, money coming from the state, from the federal government, and sort of saying to CBOs here, do it, like fix things that are happening, you know, all the inequities happening due to the pandemic. But rather that this bill will be creating some education, being able to support infrastructure for small CBOs, community-based organizations that are in the community already, and also giving them the autonomy and identifying leadership in the community. So it looks different in terms of not just necessarily having the agency granting and saying, here's the deliverables, like here's the money, here are the deliverables that we need to see from you, but rather that there is the autonomy in communities to decide what's more important for them. So more of an upstream model. And I think when we talk about infrastructure, we always think of what things need to be in place. And in this case, it is more for the community to decide what is the things that they need to prioritize rather than what is like a linear infrastructure sort of thing, but still including education, obviously a steady stream of investment to keep staff, to keep the load of work, lighter for CBOs, and to identify new leadership. So it is not one or two community-based organizations in a region trying to sustain or respond or report to the agency on all the work that is needed.
Thank you, Annie. And I see Donna has her hand up. Before we go to Donna, for a reminder for anyone that wants to raise their hand, if you go down to the bottom of the toolbar, the control bar, and you click on reactions, that's where the raise hand option comes up. And if you don't see that, click on the three dots for the drop-down menu, then go to reactions, then go to raise hand, or pop it in the chat. So let's go to Donna, and then I see one question in the chat. Go ahead, Donna.
No, I just wanted to mention, and so appreciative for Annie kind of setting this up, is that within our work groups, they work across, if you will, you allow me to use the expression, the aisle with the other pillars within the RIP, because we all know that recovery has something to do with poverty, has something to do with stable housing, has something to do X, Y, Z, education, and so on and so forth. And we actually have two work groups that are working right now together to actually lay out a plan for our community-based organizations of how we can continue to invest in them. So maybe looking at a per member per month instead of this grant patchwork over and over and over again. So I think that our communities are actually standing at the ready to give us that information that we need to actually make that happen. I'm super excited. I'm really glad you mentioned that, Annie.
Thanks, Donna. And a question to the chat, which is posed to everyone, so anyone can jump in with an answer, or Annie, Michelle, and Donna, if you'd like to. How are you engaging the LGBTQAI Two-Spirit community in this conversation? Two-Spirit plus community in this conversation? And there's a train going by. Anyone want to take on that question of how you're engaged? And it doesn't have to just be our speakers. If you figured out a great way to engage those populations, share your secrets. No one's going to chime in on that. I imagine someone is doing outreach to that population or currently thinking about that population. That's okay. Katie, please go ahead. I see your hand up and you're the one that asked. Go ahead.
Yeah, I mean, so I work for an organization called the Acme Institute. We're located in Portland, Oregon, and we are a queer and trans specific health organization. And this feels like a really important question to me, and I would love to talk more with folks about how we can work together to engage these communities. Because I think that oftentimes we get left out of the conversation. And so it would be really great to talk with some more folks about this. I know I have some ideas, and we're also working on kind of a community needs assessment project. So would love to connect with somebody to talk about that more.
Katie, what are some of the, well, can I put you on the spot? What are some of the things, if you were going to say, here's the top 3 things everybody could do better across healthcare to reach that population? I realize that outreach is not that simple and that I'm amazingly oversimplifying it, but at risk of that, what would you say were some of the key things that maybe CCOs or others could be doing better or could lean into further to reach that population?
Yeah, I mean, I think that talking to LGBTQ-led orgs is a great place to start as we are working directly with LGBTQ plus communities. Also, I was talking before, but I'm not sure if it came through because I'm using a new set of headphones. Did you get my comments before?
Yeah, we heard you a little bit. Yes, absolutely.
Okay, great. Yeah, I think that that's a really great place to start. I know that, of course, in the Portland metro area, there are a small handful of those type of, LGBTQ specific organizations. But I know that it looks a lot different throughout the rest of the state in rural areas. I guess in terms of engaging the community, I think really starting with those partners who have built those trusted relationships is a really good place to start, because if we're not engaging with that community, then we get left behind, and I think that, I mean, I know in working with this community that the LGBTQ community has also been hit very hard by pandemic. We've been hit very hard in the behavioral health aspect, certainly, because there are just not enough resources in the state to support these communities. So yeah, I don't want to ramble too much, but I would love to maybe have some more conversations about this. I don't know who to talk to about it, but would love to get some contact information.
That's great, Katie. I'm glad you joined today. Go ahead, Doug.
Thanks, Sam, and thanks to everybody on the panel. Doug Riggs here on behalf of the Alliance for Kids. The opening conversations this morning talked about homelessness, and this conversation about LGBTQ populations fits really closely in there. We work with homeless youth programs around the state, and the fastest growing proportion of homeless youth are LGBTQ plus youth. And yet the state is spending 250 times as much on adult homelessness as youth homelessness. So I'm excited to see this panel discuss this issue, and I hope it will focus more of the CCO efforts on youth. A University of Chicago study from a year ago indicated that the #1 indicator of adult homelessness is youth homelessness. So until we get our hands on this problem, we won't be able to solve the adult homelessness issue. So less of a question, more of a comment.
Fair enough, Doug. Anyone else want to chime in at this time about outreach to LGBTQ, homelessness, or put a new issue on the table?
I was waiting for Michelle to maybe jump in this, but and she can follow up. But so we as a coalition do have an LGBTQ plus health and health equity work group that we have had for almost 2 years. We hosted, and this is something that Michelle led, regional summit, health and wellness summit for this population, and have continued to work with folks in our region. And most recently, I think it was the spring, towards the end of school year, supported LGBTQ and trans youth in Josephine County. So it's just been different issues that have popped up around, the lack of support, lack of knowledge, but in terms of health equity, it has been a priority of our coalition and something that we have continued to support through not only our regional work, but also in the bills, the Real D and SOGI bill, really wanting to be something that is implemented, not just, like in paper, but locally, like what are local providers doing differently, and how are they serving individuals that are identified as LGBTQ plus. And so I can say that that's something that it is a priority of ours. We have a work group, and anything that Michelle, that you can add to our engagement and our work locally, at least.
Thanks, Annie. I'm happy to connect with folks who want to talk more. I know we have limited time here, and I'll put my contact information in the chat.
That's great. Thank you, everybody, for sharing so far. How are others feeling out there about perhaps this waiver concept for the 1115 waiver around community investment, engaging with your communities on community-led decision-making for financial investments, or certain challenges you're having around meeting some health equity or social determinant needs in your community? Kat, I see your hand up. Please introduce yourself and jump on in.
Hi, I'm Kat Mastrangelo, and I'm the Executive Director of the Volunteers in Medicine Clinic in Central Oregon, and we are a free clinic that takes care of people who are uninsured, so mostly immigrants at this point. And one of the struggles that we have is finding people with the language skills that we need, since 90% of our patients are Latino and Spanish speaking. And we have patients who could potentially help us out, but they can't volunteer, they can't work for free, they can't afford that, and they may not be have proper authorization to work. Are there any waivers we can get for special projects like that for people to help in our community?
Well, isn't that a great question that I certainly don't have the answer to offhand? Has anyone else gone down that avenue of interest and figured out? That's an interesting thing, especially as we're talking about workforce and capacity challenges and wanting to have a more culturally relevant, responsive provider population. There's a ton that makes sense there. Thank you, Kat, for raising that perhaps unsolvable question today. And I also see that Katie, who was speaking earlier, put the link to her organization in the chat if folks are looking for more information about the work she's doing. And also that Michelle from So Healthy put her contact information in the chat too. Does anyone else want to chime in with another question for the group or comment about how you're doing this work in your community? Mindy, go ahead.
So hi everyone, I'm Mindy Statlander from Health Share of Oregon. I'm really curious in a future where our health equity zones are implemented, we've got the payment model like working. How does that shape and change the work that the coordinated care organizations are doing with their community advisory councils and with the community health improvement plans? For those of you who have been sort of more in this space, do you have a vision of how those evolve together?
That's an excellent question. It has come up a lot, I know, in CCO Oregon conversations about the waiver of just CCO 2.0 brought in a lot of new deliverables, and crosswalking them in a meaningful way has been a challenge. And of course, the pandemic has made everything harder, but has really been a challenge. And I think even as we saw in this past legislative session, when there was a historic investment in behavioral health, there was also a concurrent conversation about accountability, which of course makes sense when we're using federal public tax dollars, right? But also, how do we avoid counting widgets, and how do we avoid becoming just kind of too locked into a fee-for-service mentality where we're measuring things in a way that don't make sense for where we're trying to go with transformation? And then also all the provider burnout, right? Because if a CCO is asked to report, it's 9 times out of 10 going to hit the provider as well. And we know our providers are struggling with that. That is a very real challenge. I know that we've posed a question. Has anyone else thought about how those align in the future as we move towards health equity investments, or how that would work with community-led decision-making? Donna, how do you kind of match in your documents with what happens with Pacific Source kind of mothership CCO?
Yeah, thanks, Sam. It was an interesting question immediately when we saw it come up in the waiver, because Central Oregon really was a test crash dummy around this having a community arm for a payer, right? That we were actually going to be the one that was going to shepherd those investments that I was talking about early on. And the fact that we already had carved that niche out in our region. And so we were hoping, just like every time something else comes up that looks like a new shiny rock, that we are going to be able to align those things that we do really well with whatever the requirements are around this. And I think that in some instances, we've got a head start only because we have been the community arm up until now. And in the other instances, because we haven't actually seen what the deliverables will be. Where those new partnerships may align for us in the community. Hopefully they're not too far off and that they're still in our neighborhood and we know who to call. maybe I'll call Michelle, maybe I'll call Annie, to find out how we are best able to, we don't want to dismantle what the community has put together over the last 11 years in this, what was an experiment early on. And I think that maybe folks on the call know or don't know, but this model is now being replicated in 3 other regions by Pacific Source. None of the health councils look exactly the same, but we are trying to make sure that we're not dismantling something that's actually working for the community while we actually bring more value to the community. Thanks for the question, Mindy.
Absolutely. Good question. Does anyone else want to chime in on that or lament about deliverables?
I can share that definitely through this process for this waiver, what was known as the equity zones is not something that we're looking into. We, however, did look at the CCO 2.0, which is something that we already, as coalitions, regional health equity coalitions, aligned with our local CCOs, and at least for So Healthy, that is something that we've done. Looking at the model of community advisory councils, like just all the different pieces that are there and how we align with what community needs. The model that we're looking at for this waiver, it is more of creating regional collaboratives, is what we call them, where there'll be community-based organizations with community partners who are overseeing, the funds that where the investments are going to be made, but the community and community-based organizations will be the ones making the decisions of where to make investments, whether it is social determinants of health, whether it is supporting community-based organizations to create that infrastructure and sustainability needed locally, but more so than, like I mentioned before, a linear. So it will be more depending on the needs of each region, and obviously connected to CCOs who are providing the services for our Medicaid populations.
Thank you. And I mentioned behavioral health briefly. I spend a lot of time in that realm nowadays. At CCO Oregon, there's a lot of work happening there. And also this past session, that historical investment by the legislature, similar but different from what we're looking at for the waiver, put $130 million into regional planning grants for behavioral health, specifically to go to housing and residential capacity. So when folks are coming in and out of jails or in and out of the state hospital or the youth authority, making sure there's better or any, quite frankly, community-based capacity to place them, because one of the biggest challenges we have is, I think I see lots of nods already, but I think we're all probably aware that, the aid and assist population is just overwhelming the system. And we have people sitting in ERs for over 200 days to get into the state hospital. And then there's nowhere for them to be discharged. So it just becomes a bottleneck in all of our facilities. So I do think we're seeing more and more models where financial decisions are being put out into the community and looking out. We can still maintain local control and local accountability, which is one of the fundamentals of the coordinated care model. But how are we really making sure we're empowering that community-led voice? And I think Annie said it earlier, we need to make sure that's equitable across all CCOs and all regions. That there is the same level of access and understanding across the state, and all of that. But I think that'll be a similar project where we start seeing those investments go out into regional hubs, if you will, for the behavioral health, and how that plugs and plays with all of these dollars, I think is going to be important too. We certainly have a huge houseless crisis, but we probably don't all need to try to solve it with parallel solutions, right? Like we probably need to make sure we're coordinating. And I think when it comes back to the community health improvement plan or the community health needs assessment or the comprehensive behavioral health plan or the health equity plan or the share plan, I could name 5 other plans that, we're all kind of using, they're all coming from the same data sources, and all kind of going back to those same fundamentals. So we're just not recreating the wheel. We have some comments in the chat. So Carol said, I'm wondering if outcomes assessments might be done in aggregate rather than based on individual provider basis. In smaller communities, the reporting requirements can be onerous. Not sure if the data can be extrapolated based on information the CCO already has. Yeah, that's a really good point. We also run into challenges in small communities where when we want to get down to reporting by race and ethnicity, sometimes the population is too small for us actually to call that out. And so I think we have a couple of challenges, Carol, to really kind of get to the suggestion you're offering, and that we still need to get better real D data. So race, ethnicity, language, disability, that data still has a lot of gaps in it. And some of that's due to provider reporting, some of that's due to having multiple different systems beyond Epic and MMIS and all of the different things that have to kind of plug together to make it all work. And then some of that's also, we have a lot of good things, like we have expedited enrollment for the Oregon Health Plan. So some members of the Oregon Health Plan don't fill out applications as often. So there's not as many times to collect that data and kind of make it better. And that wasn't as much of a priority in past years as it is now, So I think we probably have some time to get the data better, but I think that would make a lot of sense in the future. Anyone else want to comment on anything we've said so far, or bring any other ideas to the table? We're just about at time, but I'd welcome any final thoughts or questions. Colin, go ahead. I see your hand up.
Hello, my name is Colin Stackhouse. Can you guys hear me okay?
Yes.
Yeah, okay. I'm a member of the Portland chapter of Healthcare for All Oregon, which is a kind of community-based, Oregon-based educational and advocacy group that's been working in Oregon for 20 years. And basically, I just wanted to pipe up saying that if you don't know about our organization, we'd love it if you check us out. A lot of these topics are beyond the scope of what we're doing, but in the end, having a single payer system to move out of our very flawed insurance and payment system is critical, right? I mean, there's just no denying. So come check us out. I'm going to pop a link in the chat, and I appreciate the platform.
Thanks, Colin, for sharing that resource, and do pop it in the chat. Anyone else want to have any final comments or questions or experiences or celebrations about work happening in your community? Celebration's always welcome. It can be a little cynical sometimes. We got to celebrate when we can. Oh, I see somebody else put in a shocked face. I love reactions. Okay, great. Oh, I see Rich, you gave us a shocked face. Rich, did you want to chime in, or just celebrating our conversation here? That's great. Good. Okay. Well, seeing no other hands or hearing no other final thoughts, Colin did put the resource he mentioned in the chat, so please do check that out. And several people have DM'd me during this that they'd love to reach out, so I'm just going to throw my email right now in the chat too. And folks have asked if we're going to be able to get contact information for everybody in this breakout. Unfortunately, we won't be able to do that, but I can tell you that we topped out at 119 participants. And I will have a recording of this, which will be available later, including the chat. So that'll be available, as well as the overall program, and the other 2 concurrent sessions you can enjoy at your leisure once the recordings are available for those 2 other conversations. So thank you, Donna, Annie, and Melissa, for joining us today and giving us just a little bit of framing for the conversation. There's obviously lots of work ahead. I feel like at the next CCO Oregon conference, we'll probably know what came out of the waiver negotiations and can take this conversation to chapter 2 and see where we're at that time. But thank you, everybody, for your time today. And we're going to be on break now until 11:25, and we'll regroup on the main landing page so you can close out this Zoom. Thank you so much, everybody. Bye.